Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, welcome to the latest video cast for the Medicine Journal. My name is Albert Ferro. I'm a Professor of Clinical Pharmacology at King's College London, and I'm the Chair of the Editorial Board at Medicine, and I'm delighted to be joined today by Professor David Baldwin from Southampton. So welcome, David.
Thank you very much, and hello, everyone.
Okay. So David, can we start by you telling us a bit about yourself and what you do and so on?
Okay. Well, thank you. So I'm a Professor of Psychiatry and the Section Head for Clinical Neuroscience in the Faculty of Medicine at the University of Southampton in the UK. And like most clinical academics, I spend roughly half my time in academic pursuits, mainly research, and then half of my time in clinical practice, where I run a specialist service for patients with mood and anxiety disorders. I joined the editorial board of Medicine a long time ago, and I'm really pleased to still be involved in kind of commissioning the psychiatry chapters.
Thanks, David, and we're very pleased to have you. And the particular reason we've got you today is because the August and September issues for 2024, you're the board member who's responsible for those. So we're going to talk about psychiatry, which is the subject of those issues. Now, obviously, just for the benefits of people watching this, we won't be covering everything that's in those issues. There's a lot of material there, and it's all very comprehensive. But what we thought we might do is just sort of touch on one or two issues. And again, we won't be able to go into huge detail, but everyone who's watching can read the journals for further details. So we thought that we might start off by talking a bit about psilocybin.
Yes.
Obviously a very old drug, used recreationally, but it's been very much in the news recently as a possible therapeutic
Yes.
Could you tell us a little bit about that?
Well, it is very interesting. Apparently, there are 35 biotechnology companies who are developing psilocybin-based treatments for depression or other mental disorders. So you have to think, why is this happening? And there's actually quite a long history, but with a lot of recent interest. So psilocybin, which comes from, I suppose most people would know as magic mushrooms, kind of mushrooms that you might pick in the forest. Psilocybin in the 1960s was kind of considered a treatment that would help with the response to psychotherapy, that it would kind of ease people so that they could benefit more from psychotherapy. But of course, it fell into kind of disuse as, I suppose, more conventional treatments were developed. But interest has returned to it in the last decade. This partly comes from knowledge of the pharmacological properties and also from the findings of neuroimaging studies. So people kind of know what it does and which parts of the brain are affected. And this then led to a number of very early studies in patients with I suppose you'd call it treatment-resistant depression. So people who'd not responded to conventional treatments. And some of these trials were controlled and some were open without control. But it did seem that there were some antidepressant effects. And of course, this then led to more formal randomized controlled trials, which looked at psilocybin compared to existing treatments. And the findings from often quite small studies have been pretty encouraging. And there's a sense that psilocybin could become a useful treatment for patients who haven't responded to other approaches. Once more information is gained about its kind of safety and tolerability and long-term value.
Yes, thank you. And just to say that we will be having a spotlight article on psilocybin in the journal in the near future, so we'll be able to sort of delve into these issues in a bit more detail. What you say there, David, obviously highlights an important issue around clinical trials for antidepressant medications, doesn't it? And obviously, you know, as medics, we're used to the concept of RCTs and evidence of benefit and so on in many therapeutic areas. But I think for depression, it's been a particularly difficult area to get clear evidence, hasn't it?
Yes. I mean, the early trials with antidepressants were in the late 1950s and early 1960s. And, you know, they followed a fairly conventional randomized controlled trial approach with a placebo control. But of course, we're reliant upon rating scales to assess effectiveness. And the rating scales are based on questions of a patient. So there's always been this kind of sense that we lack an objective biomarker of response to antidepressants, and we're kind of reliant upon people's impression of how they're doing, and also expectation effects are quite important. Well, they're important in all areas of medicine, but probably particularly important in the area of psychological medicine. So people have always felt that there's a need for, double-blind, placebo-controlled trials, so you can kind of minimize the expectation effects. But of course, another way of thinking about the difference between drug and placebo is to think about clinical response. And by convention, a response is when depressive symptom severity is reduced by 50% or more. And typically in a randomized controlled trial with an antidepressant, about 50%, so about half of people are responders on active treatment, and about 30% are responders on placebo. Okay, so there's a 20% difference in response. And also, actually, if you did nothing, so that people didn't take part in the trial at all, the response rate is of the order of 20%, which is kind of natural remission of symptoms. So, of course, in real life, in everyday clinical practice, the decision is whether or not to use an antidepressant. So essentially, it's whether you've got to use a treatment that has a 50% chance of effecting of a response, or do nothing with a 20% chance of natural remission. So what you try to do is to identify those patients who are more likely to benefit from antidepressant treatment. And of course, there are biomarkers with help with that, but things like greater symptom severity and a longer duration of the symptoms are predictive of a better response to antidepressants. So what we're trying to do is, avoid the use of antidepressants in people with very mild or short-lived symptoms, because they probably have very little benefit in that group, and focusing in on people with more severe and more prolonged symptoms.
So taking perhaps a bit further then, what do you feel is the place of antidepressant therapies as compared with non-pharmacological therapies, the talking therapies and so on? There's a lot of discussion, of course, about whether doctors reach for the prescription pad too early, in all sorts of areas, with antibiotics, for example, but this is another area, antidepressant use. And what's your feeling about when is the right time for an antidepressant to be prescribed versus non-pharmacological therapies? And also perhaps just maybe, is it more useful in treating an episode of depression, or is it more useful in preventing relapse? Perhaps you can sort of give your views about that.
Yes, well, thank you very much. I mean, they're both really important points for clinical practice. So I'll take the second one first, if I may. And actually, the evidence that antidepressants are effective in long-term treatment, I think, is stronger than it is in short-term treatment. I mean, in short-term treatment, we have these kind of discussions and debates about how valuable they are. But in longer-term treatment, there really should be no doubt at all that they are effective in preventing a relapse of symptoms in people with recurrent depression, and in preventing new episodes of depression down the line. So, that's, I think, when you've got a patient with a highly recurrent illness, the use of an antidepressant will significantly reduce the likelihood of them having further episodes in coming years. So that's absolutely clear. In terms of your first question, which of course is particularly relevant in the world of general practice, really, is I think psychological treatment should be the first line treatment. And in the UK, at least, we have systems which enable the fairly prompt referral and treatment with cognitive behavior therapy, CBT, for anxiety and depression and sleep disturbance. People end up typically having between 12 and 15 sessions of CBT delivered by specialists in primary care. So I think that should be the first line approach for a sort of mild to moderate depression. For more severe depression, I think there's probably more of an argument for starting with an antidepressant, particularly if someone has suicidal thoughts, or, is not eating sufficiently, so they're losing weight, or has other what are called biological symptoms like early morning awakening and so on, which are predictive of the response to antidepressants. And that's because in the more severely depressed patients, they often can't really benefit from psychological interventions. It's just too much being asked of them, and they need to get a little bit better first before they could benefit from a psychotherapy. So in that group, the more severely ill, I think antidepressants should probably be the first line treatment. But in the majority of patients seen in primary care, the psychological treatment should be first line.
Okay, thank you. Before we leave antidepressants completely, and we're sort of spending a bit of time on this because it's obviously a major class of drugs that are used in psychiatry. A couple of other issues that arise in their use is how to get off them once they've been started, and also their use in non-depressive contexts as well. Maybe just tell us a bit about those two aspects.
Well, in terms of where they're used, they are used actually in patients with anxiety disorders like generalized anxiety disorder or panic disorder. and also in patients with obsessive compulsive disorder and post-traumatic stress disorder, where, they can work in acute treatment and again in prevention of relapse. And in fact, there's some suggestions from studies in primary care that drugs like the selective serotonin reuptake inhibitors, the SSRIs, are actually rather better at reducing anxiety symptoms than they are depressive symptoms. So there's definitely a role for antidepressants in patients with more severe versions of anxiety disorders and PTSD and OCD. In terms of getting off them, again, this is the subject of much discussion at the moment, and you often get quite marked difference of views about this. I mean, certainly stopping some antidepressants abruptly can be very difficult, and people can be troubled by distressing withdrawal symptoms for many days and sometimes for a few weeks, and some people would say even longer. So antidepressants should never be stopped abruptly. They should always be tapered. But the duration of that tapering is not really clear. Most guidelines would recommend that, when someone has completed long-term treatment, which might be a couple of years, that the dosage should gradually be reduced, probably over 3 months. The antidepressants do differ a bit in terms of their likelihood of causing withdrawal symptoms. So what are called the SNRIs, the serotonin noradrenaline reuptake inhibitors like venlafaxine, are probably a little bit worse than the SSRIs. And amongst the SSRIs, probably fluoxetine is the least likely to cause significant discontinuation or withdrawal symptoms. And that probably is due to its very long half-life. And also the very long half-life of its principal metabolite, norfluoxetine. So the level comes down over about 7 weeks of treatment. So people are much less likely to have kind of unpleasant withdrawal symptoms.
Thank you, David. That's very, very useful. Maybe we'll turn now to another set of disorders that general physicians need to know about, and they come across all the time. That's to say delirium and dementia. Something you'll see all the time on the wards. So maybe we'll say something first of all about delirium, common causes and its management. Could I perhaps ask you about that?
Yes, I mean, when we were getting the articles together for the psychiatry chapter, it was really important that we chose subjects which people are going to encounter in the general hospital. And, delirium is probably at the top. About 25% of admissions to the general hospital are troubled by delirium or acute confusional states. So it's astonishingly common and can cause really difficult problems in the management of patients in the hospital. So the causes are really varied. Sometimes delirium sort of occurs in the absence of underlying cognitive impairment. So, in young people with severe infections or undergoing drug withdrawal, or things like hyponatremia or hyperkalemia, metabolic complications, you can have these very short-lived acute confusional states. But the more common situation is in the elderly patient with an underlying cognitive impairment, which may not have been detected before admission to hospital. So on top of that, then the added, I suppose, insult of, physical illness and concomitant treatment and so on causes the delirium, which probably wouldn't have occurred if they didn't have an underlying dementia. Often dementia is revealed once delirium has resolved. So it's a difficult thing to manage. First of all, it's often undetected, and people, think that patients are kind of acting a bit strangely and doing odd things. And the really important thing is just to think about what the level of consciousness is. Some people become hyper-aroused, but other people are in a kind of state of torpor and very subdued. So there's an altered level of consciousness and attention, and of course disorientation, and that's usually in time and place, less often in person. So you look for altered level of consciousness, distractibility, disorientation, and it's a fluctuating picture. So people are often okay during the day, but much worse at night. And then you have additional features like hallucinations. It's often thought that they're typically visual hallucinations, but things like auditory hallucinations can also occur. And people can develop quite funny ideas, odd ideas that doctors and nurses are trying to poison them and things like that. So they can actually have short-lived persecutory delusions as well. I've kind of hinted on the management. The first thing is to try and isolate the patient, actually, to reduce the stimulation. So nursing them in a side ward with the lights on. People often worry that, things will be worse if they're blinded by light, but no, quite the opposite. You need the light on, because that means that people are less likely to misinterpret stimuli. And obviously you treat the underlying cause, such as the infection or the renal failure or the metabolic disturbance, and that usually resolves the situation. Sometimes psychotropic medication is needed, like a benzodiazepine, but you have to use those very carefully, because you can make people very drowsy and then you don't know whether it's the effect of the drug or the delirium. And occasionally antipsychotic drugs would be used if people are troubled by hallucinations and delusions. But the important thing to remember is that typically it's a fairly short-lived condition, and antipsychotics take a while to work to have antipsychotic effects. So usually the delirium is resolved anyway before they could begin to be antipsychotic. So it's usually treatment of the underlying cause will help. But as I've mentioned, then often you find that there's an underlying dementia which has been unfortunately revealed by this admission to hospital.
It's a vast topic, obviously, as is dementia, which was mentioned, and we can't possibly sort of go into, dementia in huge detail. But perhaps worth highlighting is some of the treatable causes of dementia to be aware of and to recognise. Maybe you could say a word about that.
Well, thank you. In my line of work, we're quite interested in something called depressive pseudodementia, and people with severe depression who are really troubled by poor concentration, forgetfulness, and even difficulties in executive function. So you can actually have an apparent dementia, which is actually due to the underlying depressive illness, and the treatment of the depression can actually reduce the cognitive problems. So that's what, it's common practice to think about that in psychiatry. But in the general hospital, things like hypothyroidism can cause a dementia, vitamin B12 deficiency can as well. I mean, those are the principal causes. Unfortunately, there are not many sort of medically treatable causes of dementia. Most cases of dementia result from neurodegeneration rather than a reversible medical condition. But it's always worth looking for potentially treatable causes such as those I've mentioned, but also things like poor hearing and poor eyesight. Having those corrected can actually be very beneficial as well. So paying attention to kind of sensory function is very important. And in fact, hearing loss is probably the second most important reversible cause, as it were, of dementia in the general population.
That's a very important takeaway message, I think.
It is, you know.
Well, thanks,
I think my wife would be particularly pleased to hear me say that. She's somewhat concerned about my hearing.
Well, hopefully you haven't developed any symptoms yet. But let's just finish off, perhaps, David, with a short discussion around eating disorders, and maybe less commonly seen by general physicians and so on. But actually, it is very common, isn't it? Especially in certain groups.
Yeah.
Classically think of teenage girls, but actually, we then don't think about the other groups where it occurs as well. Again, it might be worth just sort of saying something about, you know, what are the kinds of eating disorders and what sort of groups can they affect? And importantly, what should a general physician do if they have a patient suspected eating disorder?
Yes, well, thank you. Yeah, eating disorders are actually very common. Between 5 and 10% of young people will have an eating disorder at some point. And about 50% of those, the condition will last more than 5 years. So because they have an early onset, it can be terribly disruptive of people's sort of academic achievement and ability to get on in life. The one that we always think of course, is anorexia nervosa, which has an onset usually in the teenage years and is 10 times more common in girls than it is in boys. And some patients with anorexia nervosa will end up in the general hospital because they've lost so much weight and are actually to a life-threatening degree. But there are other eating disorders as well. The second most common is bulimia nervosa. People with bulimia nervosa usually don't end up in the general hospital, and that's because they may be a bit underweight, but not severely underweight. There's binge eating disorder, which actually, if anything, is associated with obesity rather than weight loss. And then I suppose the one that's causing most concern at the moment is something called avoidant restrictive food intake disorder, or ARFID. And that's because it seems to be becoming more common and rather little is known about how to treat it. So for anorexia nervosa, as I said, a small proportion of people will end up in the general hospital. And sadly, some people with anorexia do die, and that's always worth knowing. So what are the things that cause concern? Well, obviously, the lower the BMI, the more worried that people should be, particularly if the BMI is around about 13, and that really becomes very, very serious. Other predictors of kind of poor outcomes physically would be bradycardia and hypotension, very marked postural hypotension. People often become hyponatremic and hypokalemic. If they can't push themselves up off the floor, it's because of muscle wasting. That's also an indicator of poor prognosis. Low white cell count and low platelet count are also predictive of potential poor outcome physically. And obviously the treatment is all about gaining weight. The problem, of course, there's the nervosa part of anorexia nervosa, and this is the fear and anxiety about size, shape, and weight. And getting people to eat more and to accept changes in body shape and weight is really difficult. And I don't think could ever really be done by a general physician alone. It always requires very careful partnership with the psychiatry liaison team, the psychological medicine team, and they would be involving families wherever possible, and using a combination of approaches based on cognitive behavior therapy and family intervention, and sometimes use of medication. Clinical guidelines around the world vary, but most do suggest that there is a role for a drug called olanzapine, which is, I suppose, most well known as an antipsychotic drug, but actually it's mainly being used to cause increase in weight. And there's pretty good evidence that the psychological treatments don't really work when people are profoundly underweight. You have to get the weight up first so that people are faced with the challenge of gaining weight, and then you can actually do the effective psychological work. So getting people up to a BMI of above 15 is really the first crucial step. When it's 18 or so is probably the level where people are beginning to benefit from psychological treatments. So that's the kind of eating disorder that people see in the general hospital, although I also mentioned this avoidant restrictive food intake disorder, ARFID. This is very tricky because people just decide not to eat. They don't like the sensation of eating. They don't like the sensation of being full. They're not really concerned about weight or size or shape. They just don't like eating and they stop eating. And of course, this too can cause profound loss of weight and very low BMI. It's often associated with autistic spectrum disorder, and that too is a challenging condition, and people with ARFID in the general hospital are quite hard to help. And again, very careful and close liaison between the general physician and the psychiatrist is needed for that group of patients.
So I think the message is that as a general physician, don't try and treat it yourself. You need to get psychological medicine involved, and there needs to be a close partnership working there.
Absolutely, yeah.
Oh, thank you. Well, thank you, David. I think we've covered a fair spectrum of topics there.
Yeah.
I'd just again draw the attention of anyone who's watching this to the journal. So it's the August and September 2024 issues, where we covered these plus many other conditions in more detail. And just to say, David, it's been a pleasure talking with you. Thank you ever so much for your insights today.
Thank you very much, Albert. Thank you. Bye-bye.
Bye.